Hello and welcome back to the podcast. I'm Ian Lewins, one of the paediatric emergency medicine consultants based in Derby, and I'm really pleased to be joined today by Dr. Jon Adamson, who's a consultant in paediatric emergency medicine in Birmingham at BCH. Good afternoon, John. How are you today?
Hi, Ian. Yeah, very good. Thank you. It's my podcast debut, so a little nervous, but other than that, quite looking forward to talking to you about the article.
Excellent. And I noticed on Twitter you describe yourself as a one-paced footballer and long-suffering Villa fan. So I guess the first question was, how did you find yesterday?
Oh, very much enjoyed yesterday, Ian. I think I said to you last week, we just moved house, and the moving of my broadband and TV deal over. I'd had a very rational conversation with my wife about what we do and don't watch, and then the moment I found out that all football was on, we've ended up with the VIP Ultra HD package. So I really enjoyed the most boring game of football
Yes.
probably ever to be shown to such a wide audience.
The most thrilling 0-0 ever.
Yeah.
Yeah, excellent. But we're not here to talk about football,
No.
which maybe for another day. But we asked you, and you very kindly agreed to come on to talk about the article that you've written with Tom Waterfield,
Mm.
which appears in this June's Archives of Disease in Childhood Education and Practice. And it's one of these really good 15-minute consultation papers that Education and Practice publish. And you've written one on the limping child. And I guess my first question to you is, why was there a particular reason you picked the limping child for this?
Well, I mean, first of all, I totally agree with you. I think it's the 15-minute consultations are such a great format. And Tom and I had worked the year before on an article together about preseptal cellulitis, and really we were then sort of given a slightly blank slate to say, right, what do you think is a good topic within pediatric emergency medicine? Obviously, we won't rehash something if we've published something on it last year, but then we proposed LIMP on the basis that it's very common. I think it's a really interesting topic in the sense that it can present to multiple specialties, and I think when you look at how we propose as PEM doctors in this article to manage it, it's quite different. Well, not quite different, but there are subtleties to differences compared to, say, how an orthopedic surgeon may write the same article, or even how a general pediatrician may write the same article. So you can see from the references, for example, that we've picked a similar article by Dan Perry, who I'm sure lots of people will know about from his involvement in so much orthopedic research. And there's certainly differences, say, in how we may risk stratify versus how an orthopedic surgeon may do so. And that probably reflects the patients that present and the relative sort of pre-test probabilities of those patients and things. So we just thought it was quite a neat topic really to cover, and one that's both pertinent and actually quite common.
Yeah. So this is, the approach you guys have taken is the limping child who presents pretty acutely to the emergency department. Yeah.
Yes, absolutely. Yeah, and I think that is the key thing really is the most of the time in this. Certainly, if you look at our kind of quite simple, really flowchart on the last page, it is really working on the assumption for the most part that this is a pretty acute presentation, and really by that we mean less than 72 hours of symptoms.
Yeah. I think one of the really nice bits in the article that struck with me is you're trying to, with this acute presentation of LIMP, you're trying to maintain a balance throughout of, I really don't want to miss something that's important. And you've sort of said this is potentially life or limb threatening, versus I really don't want to over investigate, which the vast majority of which are likely to be nothing too serious.
Yeah, that's precisely the right point, Ian. I think and to be honest, that in itself is almost an answer to why we chose this topic. Just coming back to the previous question, because it's one of those typical pediatric dilemmas of the presentation where the vast majority of patients will be completely fine and self-limiting, but those that aren't will have something horrendous. And how do you balance the risk stratification of knowing that, probably 99 times out of 100, everything will be fine, but on the one instance where it isn't, you may miss something that either is very, very urgent or indeed is very, very serious. So in fact, it's virtually the first thing that I wrote on my notes preparing for this, really, is to go to sort of take beyond the simple sort of dilemma of missing something in inverted commas versus over investigating. I think we've tried to take the article to a point where we firstly don't miss something totally different. So you're kind of making sure that there's a framework for a robust assessment. So, for example, not missing the fact that in fact they're limping because they've got right iliac fossa pain and actually have appendicitis.
Yeah.
But assuming that we sort of do a thorough assessment and believe that the hip, or at least the limb, is the reason for their pain, then trying to strike a balance between who do we need to do thorough, immediate workup on, who do we and who do we do nothing for, but when do we see those patients again, to make sure that if the sort of second line of conditions that might be a bit more chronic and aren't necessarily life-threatening on day one, how are we also making sure that we still don't miss those patients? And that's why it's quite a neat topic, I think, really.
Yeah, and I think that fairly early on in the introduction to this, there's a really neat. I think it really summarises it well in sort of saying, we're attempting potentially to do three things. Let's not miss the high risk ones. Number two, let's try and make a diagnosis if we can. And I think almost more importantly than all of these, let's manage the risk where we're not sure what the diagnosis is. And that's a lot of what we do in ED is risk management, isn't it?
Yeah, precisely, and yeah, you hit the nail on the head. Exactly, it's that's what we are really in PEM, is risk managers. Our days for the most part are not spent making clever diagnoses a lot of the time, but they are spent honing the skill of managing and mitigating risk. And I think this is the case of the limping child is a classic example of that.
Yeah.
For the reasons we've just described, and I'm sure we'll come on to.
Yeah. With that in mind, I was thinking about this last night, and I don't know what viewpoint you take. When you're sort of seeing the child with the sort of the atraumatic limp, do you start with a mindset of this is likely to be nothing and I'll escalate it, or do you start with the I don't want to miss anything serious and I'll de-escalate it? I don't know if you've thought about
Yeah, it's a good question. I'm trying just to think what the answer to that is. I think actually that probably depends on the age of the child.
Okay.
If it's a toddler, I think my assumption is that it's going to not be anything serious, but I'm obviously wary that I need to be able to prove myself wrong on that. I'm always more wary when it's someone older, particularly a teenager, because I think with the teenagers, I start from a position of I mustn't miss a Sufi, and if it's not serious, then great, but let me prove that it's not. Whereas if I've probably got a toddler who looks well and is bouncing around, but just with one leg doing more work than the other, I'm probably more inclined to assume it won't be anything serious, but go and try and find if I can find any reason why I should suddenly think that it is. But yeah, it's an interesting way of framing it, and I think that there's probably a split there between the ages in terms of whether I go in assuming it will be nothing, or whether I go in worrying that it's going to be something and having to prove to myself that it's nothing.
And I don't know if you guys at BSH have people who are sort of adult trainees who are coming to do their pediatric placements with you.
We do, yeah, we do.
But do you find the mindset in those trainees tends to be different from, say, the pediatric or the PEM trainees at all when approaching children like this?
Not necessarily. To take those groups, if you like, we have some senior emergency medicine trainees who are near to completion of their training, and they're doing time at BCH as PEM subspecialists, and I think they probably approach these types of cases with quite a similar mindset to our experienced grid trainees and people like that.
Yeah.
The where the greater range is probably the both in our ST3 pediatric trainees and in the EM CT3 trainees, in terms of there may be differences in terms of their comfort or previous experience of examining a lot of children. But equally, I think that a lot of our pediatric trainees may come from a mindset of more general pediatric approach to this type of thing as well, which I think I alluded to earlier on. Your pretest probability, if you have been referred to a general pediatrician by a GP, may well be that actually your pretest risk is slightly higher because you've been
Mm.
through um, you've sort of been through a primary care triage, if you like, prior to being referred on. So I think probably adult emergency medicine trainees who are relatively inexperienced in their pediatrics, or junior pediatric trainees who have mostly had experience in general peds so far, are probably both on the more cautious end of things, actually. And I think that's probably also borne out by if they ask advice from our orthopedic colleagues, because again, their pretest risk is usually higher by the time it's been filtered through primary care or through a secondary care referral. So they're probably a bit more inclined to investigate too. Whereas I think we are, in those of us who work full time in PEM, as you and I do, are quite used to seeing the sort of full gamut of very minor limps, where you know that 9 times out of 10 you're going to send them home and not really have to worry about them again.
Yeah. So, taking our child that comes in, I think for people looking at the article, there's sort of several really useful boxes on this. There's the one that I think is fairly common to people, is looking at the age range and what are the likely diagnoses. And obviously, we always have in our mind, it varies from child to child, and I don't intend to read out a table. One thing I did want to just ask you about was, in the sort of differential diagnosis of atraumatic limp in the young child, you've listed toddler's fracture, which I thought was an interesting view of sort of atraumatic. And is that deliberately there because these are often very minor traumas that don't necessarily occur to parents at the time?
Yeah, precisely. Yeah, I think the I think that's exactly right. I always have particularly the children who are within, say, 6 months to a year of starting to walk, um, even with no reported trauma, it will always occur to me to try and look clinically for that. And because sometimes this is as simple as a cruising child who has sort of slightly fallen on their own heel, how they drop to their bums like they do when they just slightly either give up or have lost control of their cruising, or even a toddler that just doesn't quite, who has just started to walk, who doesn't quite coordinate, and it may be very, very minor. But it's certainly, I've certainly seen ones where we've ended up concluding that there's been a toddler's fracture with very, very minimal, as it were, trauma in inverted commas.
Yeah.
So yes, it's in there precisely for that reason. It's also, um, I think, quite an important part of your examination, and quite a neat way of demonstrating the likelihood of one or the other. If you sort of imagine you're looking at, when you're thinking about the most common differential being a transient synovitis of the hip, your toddler's fracture is very much the other end of the bone. And I find it quite useful when, sort of teaching trainees about the examination, to consider how you may, with limited history, how you may elicit that the pain is coming from the hip, or how you may elicit that the pain is coming from the distal tibia, by different ways of loading or examining the gait. It's often quite a neat way of working out which end of the leg, if you like, is hurting for a child who can't tell you, and a parent who may not really have witnessed any significant injury.
Yeah, because as you say, in one of the, I really, really like the table that talks about pitfalls in these children, and as you sort of comment on quite early in the article, it's leads to potential over investigation when you're not quite eliciting where the pain is coming from. So the classic example being, knee pain and getting very focused on the knee, and actually this is actually referred hip pain, for example, from a Sufi or something like that.
Yeah, absolutely. And I think whether it's a Sufi in a teenager, or sometimes the parents of the child who can't really tell you, who's only 1 or 2, it's certainly quite common for knee pain to be the apparent presentation, but for the hip to be the source. I have to say, if I remember correctly, it was Tom's idea to put the pitfalls section in, so I probably should give him credit for that. But I think it has come out quite nicely, actually, and we sort of bounced a number of those back and forth. And I think looking at various other articles, and when you speak to other specialties, they're probably more likely sometimes to know where those pitfalls are. And I think the one that strikes for me is this is an uncommon cause for the limp, but the the one that talks about not recognizing that the pain is actually coming from a long bone rather than from a joint,
Yeah.
And may in fact be I say a pathological fracture or a tumor in the bone or something like that, is one that resonates with me, just in the sense that that is one of those things that falls into the rare category, but one that you really wouldn't want to miss. But I think hopefully the purpose of the pitfalls table is to enable people to read this and feel that they can still feel confident doing these sorts of examinations, but knowing where the rarities are that they don't want to miss, and hopefully then still be able to strike that balance between not over investigating, but also having a few tricks up your sleeve to try and elicit those rarer causes or the more serious or chronic causes.
Yeah, and I think the nice thing I think about it is that the pitfalls table struck me as a collection of stuff consultants have missed and horror stories they've got over the time. So the things like the one child that will present who's got leukemia, where you've not felt for a liver or a spleen or lymphadenopathy, or missing testicular torsion presenting as a limping gait, that sort of thing.
Yes, absolutely. And I think it's what I think since we're talking about the table as well, I think it's what I quite like about it is it just shows really the importance of a thorough initial examination, really, because actually, as you said, it is kind of a collection of those things where people have been caught out, I suppose, ultimately, and it is experience more so than it is science, if you like. But it's quite a good framework for realizing that, yes, we're talking about a limp, but we might actually be talking about something wrong with your blood, your abdomen, your scrotum, your hips, your knees, your femur. Who knows what it could be? But actually, and I think it's not. I don't think actually in the pitfall section, but one of the bits that Tom had put in the original examination was about remembering joints above and joints below, and thinking about the sacroiliac joint and the lumbar spine and things like that as well. And again, rare things, but not missing things like discitis or psoas abscess or anything that might be lurking.
Yeah, and I think it emphasises how important it is to take a good history and examination, really, doesn't it?
Yes, absolutely. Yeah, absolutely.
So I guess in my mind, when I'm sort of seeing a lot of these kids, I was thinking about this last night. What's my baseline? Where am I coming from? And as you say, it varies from age to age. I guess the one thing in my mind is always, is this a septic arthritis?
Yeah.
Um, as sort of my main worry. From your experience, how easy do you think it is to pick up these kids with septic arthritis?
I think it's harder and harder, Ian, to be honest, because I think of when I did emergency medicine or did pediatrics at medical school, and that would have been age myself too much, but that would have been the mid 2000s, and we were very much. It almost seemed like septic arthritis is quite a black and white thing. If you've got a hot red joint, then basically it gets drained and you find out whether there's an infection. But in practice in 2020, it's not as common as that. We see way more transient synovitis than we do septic arthritis, and you have to have that. I think you're precisely right that it has to be in your mind for every one of these kids, because if it isn't, then you will miss some. And if it's at the forefront of your mind, then you can work back from that situation and sort of prove to yourself that it's not that. But I think if you're not anticipating that it could be, then that's where you're likely to go wrong. But
Yeah.
certainly, the actual rates of true septic arthritis are somewhat lower since particularly the HIB vaccination and that sort of thing means that in 2020 your risk of getting a septic arthritis is not really especially high, and you're even amongst the children who do have a limp, it's not especially high. But then if you miss it, then it can be very debilitating. So, the slightly old adage of it's just an entirely clinical diagnosis, I don't think is really true anymore. And the COCA criteria and the sort of modified version that the older Hay guys did, where the ESR is replaced by CRP. For those who haven't read the article, the 4 criteria being fever above 38.5, inability to walk, so not just limping, but inability to weight bear. The original was a high ESR over 40, although that's since been modified to a CRP over 20, or a white cell count above 12, I think provides a really solid framework for assessing these kids. And, in many of these things, historically we've said no, this should be primarily a clinical diagnosis, and then it should be a microbiological diagnosis once you've taken a sample. But actually, I think when you look at the table, well, we've got it in table 3 in our article, but the risk profile of having multiple features of COCA suddenly allows you to actually risk stratify these children quite effectively. When you think that having only a single feature, so if fever is your only feature, then actually, if you've got normal bloods and you can still weight bear, then these kids probably do in fact just have a transient synovitis that happens to be more contemporaneous with their viral infection as opposed to post-viral. Your risk of septic arthritis being 3% in those kids. Whereas if you are actually not walking, you're still febrile and you have abnormal bloods, well then actually it's shown that this is quite well validated in saying you have a very high likelihood of having septic arthritis. So I think it's a really neat risk stratification, but it means that bloods are potentially a very useful thing. So I sort of ended up going a bit around in circles with that explanation. But I suppose what I mean by that is that for me, if you are therefore able to weight bear, albeit limping, and you are afebrile, and essentially, taking out all those other pitfalls and all the rest of it. But if we're talking simply about transient synovitis versus septic arthritis, if you've got a well-looking child who's afebrile and can walk but is limping, then actually you may well be able to justify not doing their bloods because they already have a maximum of 2 features.
Yeah.
If you've got a child who is febrile, cannot put any weight through that leg, then equally you're already halfway there to a diagnosis. So in addition, the bloods will probably confirm your suspicions.
Yeah, it's a really nice, as you say, it's a really nice framework to be able to put on. I think the thing I like most about it is that this was clearly an orthopedic thing to start off with, and the paediatricians have got to it and changed the ESR, which we could never get for a CR.
Yeah. No, precisely. I think it's a pragmatic change, which ultimately remains well validated, and it certainly makes everyone's life easier. But yes, as you say, it's certainly a very neat orthopedic framework, and I think one that we've adopted quite nicely.
Yeah, to something that actually works in our department.
Yeah, exactly. Yeah.
The rest of the article talks about the other common things that we sort of see, the Sufis and the I say common, the Sufis and the Perthes disease, and again at the end there's in figure 4 there's a box at the end which is a really nice framework of sort of an approach to the child with the limp, Is that something that, I mean, seems very, very similar to the protocol that I've got in my department. Is it sort of pretty much what you've got in your department?
It's actually it's probably bears the most similarity to the Leicester Royal flowchart because when I started writing this, I was still a registrar in Leicester. Um, it is not a direct lift, I will say that, but it's slightly my spin on what the Leicester guideline was like. And I think actually it referenced. I was surprised I didn't notice that. I thought I'd referenced the Leicester guidelines in the references section, but certainly have referenced the RCH Melbourne
Yeah,
guideline. And I think it's probably a bit of an amalgamation of trying to simplify what obviously Tom and I have said in the article. But in terms of its basic structure, it's probably a slight hybrid of the LRI guidance and the RCH guidance. We actually do have a more recent BCH guidance now, which funnily enough wasn't actually done by me, but Chris Bird, who's our guidelines lead, has drawn up something, to be perfectly honest, quite similar to this too.
yeah,
Um, it's interesting. It's quite a challenge writing a good flowchart, is what I learned doing this, because your temptation to regurgitate the full detail of what you said in the article
yeah,
um, is certainly there, but doesn't really help anyone because they may as well have just read the article. Um,
yeah,
but equally, the simplicity of it means it has to come with a fairly heavy caveat of, there does need to be some detail on the
yes,
bones. So we Tom and I batted it back and forth a couple of times, trying to get the balance between it being overly simplistic versus not just rewriting the whole article in
yeah.
a sort of chart form. So I don't think it's a perfect flow chart if I'm being self-critical, but it's a bit of a framework to go from.
Yeah. It's, I think, really nice that at the top of the flowchart is the very important two words: give analgesia, and because you know, particularly with your transient synovitis kids, you'll go from they can't walk at all till they'll be pretty charging around the department. I guess the worry for some people is, oh, aren't you going to mask something by giving pain relief? And it's really important to say, no, you're not.
Yeah, quite. I mean, you've said it right there. Really, I mean, first of all, it's obviously the humane thing to do if a child is in significant pain. But also, I think quite rightly what you just said is um, it's funny how many parents bring their child who's limping, but don't really think of that as being pain,
Mm,
if that makes sense.
yeah,
Um, there's and maybe just because they haven't necessarily put two and two together, because obviously they aren't necessarily in pain, but the way that they're avoiding pain is to limp. And as you quite rightly say, particularly the vast majority of cases which are ultimately mild self-limiting conditions, you see a different child 45 minutes after they've had some ibuprofen, and that again enormously helps your ability to reassure the parents. And like you say, the child who's got leukemia or the child who's got septic arthritis most certainly does not look better 45 minutes after some ibuprofen. So
right,
it's very useful to your own assessment as well as obviously the right thing to do for the child.
yeah. The last thing I just wanted to chat with you about the flow chart, something that we've talked about locally a lot, is the idea of follow up. So for the child who sort of the 2 to 9 that's able to weight bear, that you're sort of saying, I'm presuming this is a transient synovitis. Our flowchart is very similar to yours. It sort of says something like follow up in 5 to 10 days. Um, and I've always wondered how necessary that is if you've got appropriate safety netting in place. Because a lot of the time, if I've seen these kids in my follow up clinic, we meet up and go, "Are you fine?" And they go, "Yes, I'm fine." And you go, "Thanks very much."
Yes.
So, what are your thoughts about sort of following up these kids?
Yeah, it's a really good question, Ian. And I think, funnily enough, Tom and I seemed in reasonable agreement when we wrote this, which was good because we probably could have debated. Had we been on opposite sides, we could have debated it forever and never reached an answer because everyone seems to have slightly different thoughts on this. The first of all, to address the time, I think that I've seen various guidelines which suggest follow up in 48 hours, things like that. Our rationale for saying 7 to 10 days was that if you have made a thorough enough assessment first time round, there shouldn't, and you've safety netted appropriately, there shouldn't be anything that requires you to review them in 48 hours. Really, those kids we're following up because if they're still limping in 10 days, or 7 days or 10 days, despite being on regular analgesia in that time, then the spectrum of more chronic conditions like Perthes, or even a sort of, it would be too early to make a diagnosis of JIA, but more inflammatory conditions, your pretest probability has probably, if you've had 2 weeks of limping, has shifted quite dramatically than if you've presented in less than 72 hours, as is kind of our assumption for the framework of the article. So, and again, if likewise, if you only set that at 48 hours, then there'll be comparatively several more children who actually still do just have transient synovitis, who you've not quite given them long enough to just get better from it. So that's kind of why we picked that time frame. I think in terms of whether you arrange to formally see the child, obviously we wrote this article well before any of us knew anything about COVID-19. But I think we have just sort of anecdotally, I suppose, shifted our practice slightly for these kids in that we're now mostly doing telephone triage for these kids in about a week. And actually, I think that is, to be perfectly honest, equally as good, if not better, a solution to bringing them back to a review clinic. Because, as you say, the vast majority of the time you just ring up and say, is he still limping? And they say, no, he's absolutely fine. In which case you say, brilliant, that's the end of that. And it's, I think you can then fairly easily triage which ones you feel you will need to bring back and formally reassess. Without necessarily dragging people up to the hospital. I think over the time, since thinking about this article and since writing it, I've gone back and forth as to where, and I think I do, even in my own clinical practice, go back and forth as to whether or not I even feel having any follow-up is necessary, versus feeling like I probably should. And I don't know there's a definite answer, but I think if you were to ask me right now, as it were, during the time and place that we are in, as it were, my general advice at the moment would be, I think that a phone call about a week to 10 days after the initial presentation is probably a sensible sort of midpoint to that discussion.
I think, and it's one of these things that it's one of the circumstances where COVID has potentially done us a favour. That all these kids that we were bringing back, actually, it makes us stop and think, well, why am I bringing them back? And what benefit does physically seeing them confer to me? It's nice for us, but actually it's travelling for parents and it's paying for parking for parents. All those sorts of things that may be a simple phone call, if safety netted well, we could easily sort out.
I think that's absolutely right. I mean, getting into the centre of Birmingham to come and see us is a hassle, to be perfectly frank. And if we can avoid people having to, then it's mostly beneficial for them. I think it's applicable. I mean, we have essentially not done a proper ED review clinic since the COVID restrictions all started, and it's interesting how remapping the sort of patient journey for all of those kids. I appreciate we're going a little bit off the limp topic here, but the kind of remapping the follow-up or referral onwards or safety netting pathways for a lot of these kids has shown that actually we are probably bringing a lot of these kids back physically unnecessarily. And I totally agree with you that I think it will, is having and will continue to have an impact on how we plan these services in the future.
Yeah, there's lots of QI projects in there for things.
Yes, absolutely.
So thank you so much for joining me today, John. And as I say, I do like these 15-minute consults. And this is in June 2020, volume 105, issue 3, Education and Practice from the Archives of Disease in Childhood. And I'd encourage everybody, it's a really great article. It's a really nice, succinct, with the pitfalls in there. It's a really great article. So thank you very much for joining us today.
Not at all. Thank you. It's been a pleasure.